Okay, we're going to talk about valvular heart disease. I'm going to begin by talking about some terms that you've heard before in 202. Most definitely, valvular heart disease does affect the cardiac output and stroke volume mainly. I went ahead and added your preload, afterload. Cardiac output, I can explain that by that cardiac output is a number. It's not something that the heart does like afterload and preload. It's actually a volume. If you think about your left ventricle and you think about it pumping the blood out of into the body, if you held a bucket there instead of the aorta and caught the blood that that left ventricle pumped into this bucket, that's what the cardiac output is. It's that volume of blood pumped through the heart in 1 minute, usually around 4 to 7 liters a minute. So that's quite a lot, that it's pumping. The left ventricle's the workhorse of the heart, but the amount in a minute that's caught in that bucket is the cardiac output. Like I said, that's normal. It depends on body surface and all the different kinds of things on that variation or that range. Some books will even say it's 4 to 8. Your book in ICHE says it's 4 to 7 liters a minute. Stroke volume is the same thing. It's a mathematical volume amount. So it's the amount of blood pumped out of that left ventricle each contraction. So that's what the stroke volume is. It's just an amount, 65 to 70 milliliters. Preload is a degree of that myocardial fiber stretch at the end of diastole and just before contraction. We know the Starling law that the more the heart feels in diastole, the more forcefully it will contract in systole. So it's all about stretching that out, the myocardial fibers, and filling that chamber up. Afterload, sort of like a rubber band, it's the pressure resistance that the ventricles must overcome to eject it through to the body. So it's like the rubber band stretching and stretching from that volume of preload, and once it stretches, it contracts forcefully. It has to get that blood out and through the valves and into the venous system. So or the peripheral blood vessels, I should say. So it goes through the aorta. All right, just some terms there. Let's start with aortic stenosis. Aortic stenosis in itself means just hardening. It means narrowing, but mostly hardening. So whether or not it's valves or anywhere else you hear stenosis, you know it has something to do with hardening. This is where the aortic valve is actually narrowed because it's hardening, it's narrowed, usually from calcium deposits. It can obstruct that left ventricle outflow during systole, resulting in ventricular hypertrophy. So it stays in instead of being pumped out because that valve is so narrow it can't all get out. So it's just staying in that ventricle. This will lead to left ventricular failure. And then it will lead to right ventricular failure. And with these heart failures, there's going to be a decrease in cardiac output. It's going, and like you know that the left heart failure, the blood will get back into that left atrium, then it will get back up into the lungs, keeps backing up, and that's where you hear those crackles and all that fluid and stuff like that. So it's no surprise that the signs and symptoms are dyspnea, angina, just from the heart working harder. The patient can get very syncopal episodes on exertion. Late in the disease, it can be marked fatigue with peripheral cyanosis because they're just not getting cardiac output. So their body's not perfusing down to the tissues where it should be. A narrow pulse pressure, and you will hear a murmur with these valvular heart diseases. Many times they will have AFib. With all the heart diseases, it can always be risk for their heart to go into atrial fibrillation. When it does that, then there's a big likelihood that an emboli can happen. So that's always a concern, and always should be in our minds when we're assessing these patients and treating the patients, that these patients could definitely suffer an embolus. This is a good picture. It shows the aortic valve in the normal heart, and you see here. But here you see the aortic valve in an aortic valve stenosis heart. And you can see here where if the blood is in the ventricle trying to pump through this aortic valve, not a lot is going to get through. So it's going to fall back into this ventricle, and it's going to cause hypertrophy to that ventricle. It's going to cause, because there's going to be, the next time it contracts, it's going to be more blood there than, because it didn't get it all out. And then it tends, the body compensates by making the ventricle hypertrophy to hold the bigger volume, which then in turn causes problems. So, how we can diagnose this is pretty much through chest x-rays. We can look at EKG changes. They can certainly look at all this on a heart cath as well. And we'll probably be treating with some digoxin just to help the heart beat more efficiently. Some diuretics just to keep less volume down, so we're going to restrict sodium as well. There's also a procedure called a balloon valvuloplasty that's covered very well in your IGI. In the chapter where, it's chapter 37, I believe, care of a patient with cardiac problems, yeah. And what they do is, this can be very non-invasive as far as not a cut or anything. They can go in, they can thread a wire up to that valve. They blow a little balloon up, which can help shape the valve back into a place where it's more functional. It's sort of like when we put in a Foley catheter. We tend to just slide that Foley catheter up into the bladder, and then when it's up in the bladder, we blow a balloon up. Well, that's the mechanism of the tube, but not, how, most definitely with valvuloplasty, when you blow it up in that valve, it's going to affect that tissue, which it doesn't in the bladder, but maybe not a good comparison there, but valvuloplasty, it helps shape the valve. And then they most certainly can be candidates for an aortic valve repair. And again, AFib is always something that we're going to look at. In your IGI book, it does talk about how IV cardizem can convert them out of AFib into normal sinus rhythm. Or they can go in to get something, what they call synchronized counter-shock cardioversion, where they just use the shock paddles like we would if we were, on a crash cart sort of kind of thing. And when we shock them, it can convert them. If that doesn't convert them, then they would need to put them on something like amiodarone to make sure that, to help with that AFib. Then there is the aortic regurgitation. Now, aortic regurgitation is really the opposite of the stenosis. The valves are just not closing tightly. It tends to leak blood backwards because it's not we want our valves to be unidirectional, right? Because we've got to get it in one place. It doesn't need to move back up into the other place. But most definitely with aortic regurgitation, that's what happens. The valves are just loose. They're not very tight, they are weak, and it will just not close properly. It allows blood back up into the atrium, and it will cause a lot of problems. They can be asymptomatic for a while. Later, they do get that left ventricular failure, and with all of the different things here that you see on my slide, they can get tachycardia. Of course, what happens is that decreased cardiac output, and the tachycardia is because the heart's trying to work harder to try to pump some blood there that it's trying to pump the blood that's not there to really pump. So because it's flowing back up into the atrium. Most definitely, these chambers will be hypertrophied. Diagnostics will be the cardiac cath. Here's a good picture of it first. Here's your aortic valve. The valve closes, the left ventricle pumps the blood into the aorta, but the valve does not close completely, leaking blood into the heart. So this is what happens here. Okay. So we're going to do cardiac caths, chest x-rays, EKGs, and echoes are normally done for these types of patients to try to diagnose their problem. We can give them digoxin, some anticoagulants, especially for, the risk for emboli, and then the AFib again. Then let's go to the mitral valvular problems. First, mitral stenosis. Again, that's the hardening, narrowing of that mitral valve. It causes backflow and regurgitation in this. Not with this valvular heart disease. Valvular heart disease, it causes a thickening due to I can't even talk. Fibrosis and calcification, usually caused from rheumatic fever, even some congenital anomalies. The valves really thicken and they fibrose, they calcify, they can be very, very stiff. They prevent normal blood flow from the left atrium to the left ventricle. The left atrial pressure rises, causing the atrium dilatation. The pulmonary artery pressures increase, causing right ventricle hypertrophy. Again, arterial emboli could be a problem there as well. And here is the normal mitral valve, and here it is when it's stenosed and very narrowed. So you will get pulmonary congestion and right-sided heart failure, and that will occur first. Later, the left ventricles receive insufficient blood volume, so the preload is decreased and cardiac output falls. Go ahead and read in chart 37.6 and 759 in your EEG, the signs and symptoms. You will hear some muffled sounds, maybe a murmur. The patient certainly will be fatigued. They will have dyspnea at night and possibly palpitations and things like that. What we want to do to make sure we're going to for these patients is anticoagulants to prevent any clot formation, and then again, these patients are candidate for that balloon valvuloplasty that we had spoke before. Then with regurgitation, this is where the valve is not closing properly. There's a backflow of blood. It's not unidirectional anymore. It prevents the mitral valve from completely closing during systole, allowing the backflow of blood back up into that atrium. Then the backflow and normal blood flow is ejected with the next systole. So to compensate to that increased volume and pressure, the left atrium and the left ventricle dilate and hypertrophy, causing decreased cardiac output. And with decreased cardiac output, it can lead to decrease in perfusion, mentation changes because the brain's not perfusing, the limbs are not perfusing, the kidneys may not be perfusing. It could lead to cardiogenic shock, this kind of a thing. Causes can be degenerative due to aging, can be due to the infective endocarditis or ischemic heart disease or the rheumatic fever. You will probably hear an S3 in these patients when you auscultate heart sounds. S3 is usually always an early sign of heart failure once you hear that S3. Once you get used to it, it takes a lot of practice to get used to hearing the heart sounds. So I really encourage you to get on Google, go to sites that give you audio clips of all of these different types of your S1s and S2s, your lub-dub, and then your S3s and S4s, and then some of your murmurs and things like that. With the mitral regurgitation, this is the narrowed artery for the stenosis, but then you've got the leaking valve for the regurgitation, and that's what this depicts. The progression is very slow, can be asymptomatic for years. Symptoms, again, when the left ventricle fails due to the chronic blood volume overload, so they get fatigued, chronic weakness due to that reduced cardiac output. They get dyspnea, orthopnea, that when they get that right-sided heart failure, you're going to get that distended neck veins, hepatomegaly, pitting edema, high-pitched murmur, and a severe regurgent always can exhibit a third heart sound. So you need to see chart 37.6 in your book. Then we can talk about the mitral valve prolapse, and I have that misspelled up there, valve. But this is when the leaflets of the mitral valve gets really floppy. This can be very familial. It can happen very regularly in young women, and they don't even know really they have it. Also from cardiac defects. The young women might feel some palpitations just where their heart flutters. They can be asymptomatic for a long time, but they can start reporting some chest pains and palpitation, exercise intolerance, and some dizziness. And syncopal mitral prolapse women usually can have a lot of syncopal episodes where they just faint, pass out. You will see that they will have a normal heart rate and a normal blood pressure, and usually normal EKG. So it's not until the symptoms start showing up that they can diagnose a mitral valve prolapse. And here it is. Those floppy little leaflets here are just prolapse back into the atrial, allowing regurgitation. Certainly not a unidirectional flow anymore. Now, with the interventions for mitral and aortic disorders, it depends really on which valve is affected, of course. But the focus for all of them is drug therapy and rest, most certainly, to try to counteract what's going on. You want to assess for left ventricle failure with pulmonary systemic congestion, and then right systemic failure as well. Drug therapy, the first drug therapy is to control your heart rate and your cardiac output. They're going to try to control that first. And then the second would be to try to restore that normal sinus rhythm. So you will be seeing these patients get diuretics, beta blockers, digoxin, oxygen to improve heart failure. They may get some vasodilators to reduce the regurgitated flow. They can get cardizem to convert AFib to a sinus rhythm, and to slow the amiodarone to do some B blockers, procainamide to slow the ventricular rate, and Coumadin to prevent thrombus formation. The non-invasive valvuloplasty is covered in page 761, so you need to go in and read that. Some surgical management would be heart valve reparative procedures. They can do that direct. That's covered in your IGI. and mitral valve annuloplasty, which is also covered in your IGI. So go in and read that. Heart valve replacement procedure can be either a prosthetic valve or a biological. They both have pros and cons, and that's covered very well in your IGI as well. Also, I would like for you to read page 72 to 762 and 63 with that chart of 37-7 is home care management and teaching for self-management of these patients that have these valvular problems. And that is the end of valvular disorders. Thank you.